Thank you so much for the introduction. We'll try to make it really fast. It's good we are having a track on hypertension because it's very important as a public health issue. It's associated with many conditions and diseases. As Dr. Wangari was going through her talk, you could see the many other conditions that have got hypertension as an associated feature. And it has many adverse outcomes that we know. But because of the nature of hypertension in CKD, it is important to have in place optimal strategies to efficiently diagnose and manage it in patients with CKD. And probably that's why it was chosen as a topic in this conference. I'll say a little about the normal blood pressure pattern. Blood pressure is not a fixed figure, and so it varies, and it's got a circadian kind of rhythm. You have your highest pressures in the morning at about 10 a.m. and the lowest at about 3 in the morning. So high during the day and goes down in the night. That's normal. And this physiological control is complex, and there are quite a number of mechanisms that have been associated. One is this change, the circadian rhythm change with sympathetic tone, and this is related to the sleep and wake sort of cycle. We know that cortisol also has got a circadian associated rhythm, and whenever you secrete cortisol, you have also increased sensitivity of the blood vessels to noradrenaline. We have the plasma renal activity, which also increases early in the morning, starts decreasing in the afternoon, and starts gradually to rise during the night, and then picks up again in the morning. Then we've got the plasma aldosterone. Also, it has a diurnal pattern similar to that of renin. So all these, especially so the sympathetic tone or the sympathetic rhythm, are associated with hypertension, or blood pressure, changes in the normal physiology of hypertension. We've got a number of modalities of measuring blood pressure. More commonly, and that's what we see, we always go to the office and get a blood pressure done, and that is once every while. But later on, because that was not adequate, their people are also advised to do home-based blood pressure monitoring. They end up maybe twice a day, sometimes more often, 3 times a day. And, it helps to improve on determining the level or the average blood pressure your patient has got. And then there's the ambulatory blood pressure monitoring, which I'll be talking about in a little more detail. But for better identification and classification of blood pressure, office blood pressure alone is inadequate. We said that blood pressure tends to vary all during the day. So if you get a single reading one Monday and then come in 2 months after and you get another reading, then it becomes very difficult for anyone to determine what your real blood pressure is using office blood pressure. So a combination of measurements helps in identification of 4 basic categories or phenotypes, and these are shown. We may have, now if you had facilities and you got office blood pressure, you can only decide whether someone is normotensive or hypertensive, okay? And when someone gets blood pressure high, when they're in the office, you may not know whether that is real hypertension or is it white coat hypertension. When you have an added element of using the ambulatory blood pressure, These are the normals on the side, daytime mean, nighttime. If you use it, it can tell you if you got normal blood pressure in the office, and then you got hypertension with ambulatory blood pressure, then we call that masked hypertension. If you got a high blood pressure using our office blood pressure, that is above 140/90, and then you go at home and it's still, and it's still high, then we say you got sustained hypertension. But if you go home and according to the ambulatory pressure, you got normal blood pressures, then we classify that as white coat hypertension. So in broad terms, we tend to characterize patients, either they are normal or they've got sustained hypertension or they've got masked hypertension, which only when they are in the office, they are normal blood pressure, but when they go out of the office environment, they get hypertension, and white coat hypertension as the four basic phenotypes in hypertension classification. That is a busy chart trying to show what is capable, what each modality, home-based ambulatory blood pressure or office blood pressure, what is possible. And probably what I want to highlight out there, that if someone comes in for blood pressure within the office, and that's the only measurement one has. The rhythm, whether you got a circadian rhythm, is very uncertain. Reproducibility is poor. You can't tell whether you got white coat hypertension or masked hypertension. You can't identify it. So that column, or that with clinic or office blood pressure, has got many impossibilities. You can't tell whether the variation in the night occurs as should be in normal, and totally impossible for you to determine whether there are variations in blood pressure. Ambulatory blood pressure allows one to do a number of serial blood pressure measurements over 24 hours. I'll not go through what exactly is done, but it provides an assessment of the daily normal fluctuations. That's the circadian rhythm. It tells you about the influences of daily activity, things like if you're working as a matatu driver, or you are working as an interventional cardiologist, or you are a pilot, they measure your pressure according to your day-to-day activities, sleep, and other emotional factors. So it puts that and can tell you what happens to your blood pressure all through the 24 hours. It offers what other methods cannot offer. It is the only reliable way of telling whether the prescribed treatment, which could be lifestyle modification or pharmacotherapy, has restored blood pressure within the normal range throughout 24 hours treatment period. So all the other modalities cannot, but this 24-hour cover tells you that all through day and night, your blood pressure is well monitored. And of course, there are patients who are prone to hypotension and falls. You can also detect episodes of hypotension with ambulatory blood pressure. That looks like the chart, of course, from morning going on. You look in the morning, there are usually a surge and so on. That is just to see at the end of the day, you have a strip of blood pressures, monitored all through the 24 hours. And you are able to get daytime means, you are able to get morning means, evening, blood pressure means, systolic mean pressures. Data from longitudinal studies and from general populations and from patients with hypertension suggest or confirm that ambulatory blood pressure monitoring gives better prediction of cardiovascular morbidity and mortality. It correlates better. We know that blood pressure is associated with cardiovascular outcomes, but ABPM correlates better with these outcomes than office blood pressure. And one of the main issues or factors is the nocturnal blood pressure, which is the most reproducible and most reliable aspect of blood pressure monitoring. And that can only be gotten by ambulatory blood pressure monitoring. And the information of nocturnal blood pressure seems to correlate better to outcomes and target organ damage. So the information of ambulatory pressure is complementary to that generated by home-based home blood pressure monitoring, and even what you get in the office. So it has a complementary role. There's no way we can do everyday ABPM. If you use ambulatory blood pressure monitoring, then the adjustments of the medication, depending on that data, compared to data gotten from the office, helps us to use less blood pressure to attain the same goal. For example, if you want a patient to be controlled and you use ambulatory blood pressure monitoring, it is borne out by research that you tend to use fewer pills compared to when you are using an office-related blood pressure control. And the proportion of patients who attain blood pressure targets are higher among patients who have used ABPM as compared to those who use office blood pressure. So there are lots of advantages for ambulatory blood pressure monitoring. And these are the indications. When we share what you get, if you suspect MAST hypertension, if you got advanced target organ damage, and kidneys, if you got kidney damage and got chronic kidney disease, that would be one of the indications. If you suspect that your patient probably is hypertensive only in the office, then when you suspect white coat hypertension, you got various indications for doing ambulatory pressures. I'll say something about hypertension, some characteristics about hypertension in chronic kidney disease. Hypertension is very common in patients with CKD, and it's the most powerful cardiovascular risk factor in patients with chronic kidney disease. And as one progresses from stage 1 to 5, as there's progressive decline in the GFR, there's also a progression in the rise of the incidence and prevalence of hypertension. So you look, if you are in stage 1, there are about 36% prevalence of hypertension, going through 48. By about stage 3, you got about 60% of your patients, and 4, 5, 84% of patients. This is data from the UK, but I think that's what we realize also in our series, and probably a little higher. There's also increased severity of not the CKD, but of the hypertension. As GFR declines, the severity of hypertension also increases. The prevalence of abnormal patterns, which I'll be talking about, of hypertension also increases as you progressively reduce your glomerular filtration rate. The incidence of there's an increase in the incidence of cardiovascular associated morbidity and mortality, and an increase in all-cause morbidity and mortality as the GFR continues to decline. Various patterns have been identified in CKD, and they are the masked hypertension varieties, the things you cannot measure or see using office blood pressure. And some of these are the non-dipping or the blunted nocturnal blood pressure fall. You cannot, the other data which is masked by office blood pressure is the rising nocturnal blood pressure. There are patients who during the night, the blood pressure does not dip or go down as expected, but actually starts rising. You also can get a morning surge. Very early in the morning, the blood pressure just shoots up. And you may also get a decreased diurnal blood pressure variation. The other association with CKD is that there's an increased 24-hour blood pressure variability. Blood pressure varies, but it should not probably vary beyond probably about 15 millimeters of mercury for systolic blood pressure during the day. So it has a variation, but it is within limit. If you got increased 24-hour blood pressure variability, then we get more cardiovascular adverse outcomes. And the other one is white coat hypertension. It also seems to be more prevalent in patients with CKD. All the above patterns which I've mentioned are all associated with cardiovascular and cerebrovascular adverse events, and they all have increased evidence for hypertension-associated target organ damage. Those are the different patterns. If you take a normal pattern which dips during the night and starts rising again in the morning. However, there are those who don't dip, there are those who extremely dip, or there are those whose blood pressure rises, and there are those who have in the morning, they raise their blood pressure so much beyond what is usually expected. There are series, I think this study of 80 CKD patients from 6 studies reported from Indiana University 2009 showed that the prevalence of masked hypertension in CKD is about 8.3, white coat hypertension about 18.3%, and about 40% of the patients who, if you took office-related blood pressure monitoring alone, you thought they were adequately controlled, they ended up having hypertension at home. So single readings alone, office blood pressure measurements alone, lead to substantial misclassification of blood pressure patients blood pressure among patients with CKD. I'll run through the associations. Masked hypertension, fairly prevalent in patients with CKD, and is associated with an increase in cardiovascular disease, with an increase in target organ damage. We went through the definition that patients with masked hypertension, they've got a normal office BP, but they get an elevated blood pressure in the morning, elevated blood pressure during the daytime, and may even have elevated blood pressure in the night. In the normal population, this happens in about 10 to 20%, but the prevalence is higher in patients with CKD. In some series, goes up to almost 35%. If you don't have nocturnal dips, as far as increase in the risk of strokes and other cardiac events, and changes in target organ damage. The morning surge, the ones who get an exaggerated early morning surge, they have an increase in cardiovascular and cerebrovascular events, especially hemorrhagic strokes. And there's a higher incidence in early morning strokes, and there's also an increase in all-cause mortality and in cardiovascular events. And there's actually evidence for those who get early morning surge that they have target organ damage. Increased 24-hour blood pressure variability, which is common also in patients with chronic kidney disease, is also associated with more morbidity and mortality, cardiovascular morbidity, probably higher than 15 milligrams, 15 millimeters of mercury, more than that in your brain. In the intricacies of the diagnosis and management of hypertension, as we said, blood pressure is not static, but varies under the influence of various factors. So to optimally make a diagnosis, we need to measure it at different times. We know that our patients with CKD have got these variations even more than other blood pressure patients. We also know that our patients have very difficult blood pressure to manage. So for good blood pressure control, you need to take control of your blood pressure for 24 hours. You got to maintain a normal circadian rhythm. You got to suppress the exaggerated blood pressure variations and the morning surge. And for you to achieve all that, ambulatory blood pressure is an endorsed guideline in major, is an endorsed modality of monitoring blood pressure from all the major international guidelines. But we don't yet have a guideline which makes specific recommendation of how to use it, especially among patients with CKD. The problem we have is the ambulatory blood pressure. There's the complexity of carrying it out, the equipment that you need, and the discomfort the patient goes through getting his blood pressure done, and quite a number of patients may refuse. But you need many readings, so you must train your patient, you must prepare them for what they are going to go through. Of course, the issue of cost and accessibility, it's a wonderful assessment, but we may not be, it may not be accessible in quite a number of our settings. Acceptability by the patient and the reproducibility may not be quite, available in many circumstances. And probably the guideline which comes from the European Society of Hypertension says if you've got a patient who has a low risk for cardiovascular events, you may do home-based blood pressure and office blood pressure monitoring, but with some once in every few months, you do ambulatory blood pressure monitoring. But for high-risk patients who have target organ damage, for example, cardiovascular disease, patients with diabetes, patients with CKD, you cannot adequately make a diagnosis of their hypertension or categorize it well. You also cannot manage them adequately. All these patients need tight control throughout 24 hours, and in that case, they need repeated ambulatory blood pressure monitoring every few weeks until one gets control of the blood pressure. That's a guideline you could pick from the European Society of Cardiology or the European Society of Hypertension, and talking about the diagnosis of using ABPM in the diagnosis of hypertension in special conditions. And I think from this summary that because hypertension is very common in patients with CKD, and because it's the single most powerful cardiovascular risk factor in CKD, office blood pressure, and because we know there's an increased decline in or increase in all-cause morbidity, mortality, and as well as an increase in the prevalence of abnormal phenotypes and patterns in hypertension as CKD, as the glomerular filtration rate declines, it's clear that office blood pressure alone is associated with substantial misclassification of blood pressure and inadequate 24-hour control in patients, especially those at high risk for cardiovascular events. So information from ambulatory blood pressure monitoring, complemented by that generated by home blood pressure monitoring and office blood pressure monitoring, could be an optimal strategy to efficiently diagnose and manage hypertension in patients with CKD. Of course, for our setup, there are issues of cost, access, but if we had, if there was availability of ambulatory blood pressure monitoring from the remarks and the characteristics we have of CKD, I think it would be quite a way to go and a direction to go in our CKD patients in order to diagnose them properly and to help manage them optimally over 24-hour treatment time. I think that should be the last slide, and thank you very much.
Thank you very much, Professor Kayima, for a very clear, concise report on ambulatory blood pressure monitoring. Now we know why we do it. We should know why we do it, especially those of you who don't change the batteries of your blood pressure machines. I think it's time for us to really take blood pressure seriously.